Hello, it's Max again, and this time I'm using PowerPoint. Hopefully I sound a little better and you won't have to deal with my horrid handwriting. Today we're going to talk about all things rhythm. This is the fun stuff, people. This is what Eindhoven envisioned for us. Eindhoven Envision sounds like a gnarly rock band. Anyway, I have no financial disclosures, no one's paying me to do this, and I'm doing it solely for educational purposes because I believe EKG proficiency is crucial. Let's get started. So today we are going to be using this website called ECG Simulator by Skillstat. It is a completely free website that you can create games out of the common EKG rhythms. Who doesn't want to fill their free time with EKG games? Just kidding, we don't have much free time in medical school. But this website is a great tool to use, as well as life in the fast lane. So now on to our first rhythm. Normal sinus rhythm is first on our list. Sinus rhythm is defined by the presence of a normal upright P wave before every QRS complex. This is because the rhythm is originating from the SA node, and therefore its rate is between 60 to 100 beats per minute. This is what we think of as the normal person's heart. The next rhythm is sinus bradycardia. The rhythm is sinus because it originates from the SA node. I know this because there is an upright P wave for every QRS complex that has the same PR interval. However, the heart rate is less than 60. Certain athletes may routinely be in sinus bradycardia due to their optimal cardiac output from an elevated stroke volume. You can also stimulate the vagus nerve and cause increased parasympathetic activation, which leads to bradycardia. Sinus tachycardia, then, is most often from higher levels of sympathetic stimulation, like states of pain, fever, high oxygen demand, or hypovolemia. The rate is often between 100 to 150 beats per minute. The next thing I want to talk about is called premature beats, or extrasystoles, or aberrancy. The first premature beat is something called a premature atrial contraction. In the next three cases, I'm going to discuss isolated extra beats. There are times where these beats can become regular in things like bigeminy or trigeminy. However, we're only going to discuss these three morphologies. Speaking of that, the morphology is very important in determining where the premature beat comes from. If we think back to my heart drawing where I split the conduction system into three areas, the first area was a sinus area, where there was a P wave before every QRS and a T. The second was a junctional area, where there was no P wave, but still a narrow QRS. And in the final area, the ventricular area, there is a wide, bizarre QRS. They're stuck on those dang back roads with no highway. So, in the EKG on the screen, we can see a normal sinus rhythm with P waves, a QRS, and T waves. However, there is a beat that seems to happen earlier than it should, and this early beat has a P wave associated with it, as well as a QRS and a T wave. And then we have a period of time before the next conduction cycle. This rhythm is called a normal sinus rhythm with premature atrial contractions, or PACs. This next rhythm is another example of an extrasystole, or a premature beat. As we can see, starting from left to right, there is a P, a QRS, and a somewhat flattened T wave. Then there appears to be a beat that happens earlier than it should. This is all about morphology. This beat has a narrow QRS complex with no P wave. So, which one of our three areas of the heart does that seem like it's coming from? This will be area 2, the junctional area. So this rhythm is a normal sinus rhythm with premature junctional contractions, or PJCs. Our final and very common form of aberrancy, or premature complex, is in our final area of the heart, the third area, the ventricular area. By definition, which is hilarious to me, a premature ventricular contraction is wide and bizarre. If you were to pick out the wide and bizarre looking one, it's pretty obvious. So this would be a sinus rhythm with premature ventricular contractions, or PVCs. If these beats were to happen regularly, like every second beat, it would be called ventricular bigeminy. If it were to happen every third beat, it would be called ventricular trigeminy, and so on. Now we are going to move into the atrial arrhythmias. The first atrial arrhythmia I will talk about is something called supraventricular tachycardia. Supraventricular tachycardia, or SVT, is an umbrella term for any tachycardia that is happening in the atria, i.e., supra to the ventricles. I will discuss some of the specifics about SVT, like AVRT and AVNRT, in the next lecture. SVT is defined by a narrow complex regular tachycardia with a rate greater than 150 beats per minute. SVTs are usually caused by a reentrant cycle, like a merry-go-round, continually activating the ventricles. Not so good, but not the worst. Some of the treatment options for SVT include vagal maneuvers, carotid body massage, a cold water or diving reflex, the medication adenosine, or synchronized electrical cardioversion. The next arrhythmia is one of the most common. This rhythm is defined by its irregularly irregular nature with no discernible P waves. A good rule of thumb is that if you are squinting at an EKG trying to find P waves and you have an irregular rhythm, it's probably AFib. AFib, or atrial fibrillation, originates from irritable foci around the pulmonary ostia in the left atrium. Now that's a board's question. Treatment for atrial fibrillation includes either a rate control or a rhythm control approach. Sometimes AFib can overstimulate the ventricles, causing them to have a rapid response. Atrial fibrillation with rapid ventricular response can be an emergency. Some of the important consequences of this rhythm come from its irregular nature. The risk of clot formation and thrombus is very high. The other piece of information is that the atria are not contracting appropriately. And remember, our P waves indicate atrial contraction. If they are fibrillating, they are not contracting well. So we have lost our atrial kick, or that little extra bit to move blood into the ventricles. This next rhythm has a very identifiable sawtooth pattern in between the R-to-R intervals. These fluttering waves are originated in the right atrium at something called the cavo-tricuspid isthmus. That's another nice board question. And the definitive treatment is an ablation for this. This is atrial flutter, and atrial flutter is named by how many flutter waves it takes for the AV or junction to respond. This is typically every second or fourth flutter wave, so this would be a 2-to-1 or a 4-to-1 atrial flutter. In this case, this EKG is a 4-to-1 atrial flutter. There are 3 flutter waves for every QRS. Our next rhythm has a very identifiable straight line at the beginning of the P wave. If you ever see a line like this on an EKG, this is something called a pacer spike. In this rhythm, there is either an internal or external pacemaker pacing the atria. Just like our last rhythm with the atria being paced, this rhythm shows a pacer spike before a QRS complex. This QRS complex is wide and kind of bizarre looking. This is a ventricularly paced rhythm. The pacemaker is keeping the ventricles moving. Notice how on the rise up on the T wave, there can be some ST elevation. This is a teaser for next lecture when I talk about something called Scarbosa's criteria. Our next 4 slides will be talking about heart blocks. As the name implies, there is a block in the conduction system. There are 4 major heart blocks, and they are separated into 3 categories: a first degree, second degree, or third degree. And the higher the degree, the sicker the patient. I'd like to share a poem with you that was mentioned to me at some point in my training. It is the poem of a failing marriage, but first, let's go through these 4 slides. In this EKG, we can see that there is a P wave and a QRS and a T wave. However, the PR interval is looking quite long enough to say that it's farther than one large box. Remember from my other lecture, I talked about the PR interval being anywhere from 3 little boxes to 5 little boxes, or from 3 little boxes to 1 big box. Unfortunately, this free website doesn't have the little boxes, we only have the big one. This is adequate enough to show that the PR interval is greater than 200 milliseconds, or 1 big box. And by definition, this is a first-degree heart block. However, we still have all of the components of the cardiac cycle. So this rhythm's full name is a normal sinus rhythm with a first-degree heart block. Including the normal sinus rhythm will get you bonus points, especially with that one picky cardiologist or those nurses who've been doing this for a long time. you're going to start to notice a pattern forming. Our next rhythm is defined by the PR interval once more. However, this PR interval progressively gets longer and longer and longer until a QRS complex does not make it through, i.e., you drop a beat. So when you have a longer drop, or any iteration of that, you have a second-degree type 1 heart block. This is also called a Wenckebach. The second-degree type 1 heart block may be caused by enhanced vagal tone, myocardial ischemia, or pharmacological effects of calcium channel blockers, digitalis, or beta blockers. Once more, this rhythm is defined by the PR interval. Looking at this EKG as a whole, we can see there is a long period of time on the right side of the screen where there is no QRS complex, meaning there is no ventricular contraction, meaning there is no cardiac output. That looks pretty bad, doesn't it? And indeed it is, worse than our other heart blocks so far. In this rhythm, our PR interval does not change like it did in second-degree type 1. The PR interval stays the same, and at almost random we drop beats. This is an irregular rhythm that needs very close monitoring and a cardiologist. The irregular nature can cause a low cardiac output, and eventually this can progress to our next rhythm. Our final heart block is a third-degree or complete heart block. In a complete heart block, the atria and ventricles are no longer talking to each other. There are lonely P waves that are not accompanied by a QRS complex. A good rule of thumb is that if you see more P's than Q's, you should get moving. These are chaotic PR intervals, they make no sense and they don't line up. However, if you were to map out the P waves across the rhythm strip, they would be moving at their intrinsic rate set by the SA node. The SA node is trying its best to talk to the ventricles, but the ventricles aren't listening. The ventricles are also moving at their intrinsic rate, which, if we think back to my heart picture, can either be paced by the junction or the ventricles themselves. In this case, we know the ventricles are pacing this rhythm for us because the QRS complex is wide and our rate is between 20 and 40 beats per minute. In contrast, if our QRS complex was narrow, with a rate of 40 to 60 beats per minute, we would say that that is a junctional rhythm. This dyssynchrony is very ominous because there is poor cardiac output with a high likelihood of progression to lethal dysrhythmias. A patient like this may often be hypotensive due to the low cardiac output, and they cannot increase this through their heart rate. They often will require transcutaneous pacing in an emergent situation, and eventually a pacemaker placed. In an earlier lecture, I mentioned how the right coronary artery gives rise to two branches that feed the SA node and the AV node. Thankfully, they're called the SA nodal and AV nodal arteries. The potential of a right coronary artery infarction to cause ischemic damage to the nodal tissue can and does precipitate a complete heart block. Now, with all that being said, let's summarize these 4 slides with my failing marriage heart poem. In the first-degree heart block, the husband comes home late every night. This is a PR interval greater than 200 milliseconds. In a second-degree type 1 heart block, the husband comes home later and later and later and then doesn't show up one night. In a second-degree type 2 heart block, the husband shows no signs at all and just doesn't show up one night. This is worse for their marriage and clinically. And in a third-degree heart block, they're no longer talking to each other and they've gotten divorced. That's kind of sad, sorry, but it stuck with me and I hope it sticks with you guys. Our next rhythm, again, like my heart that I split into 3 areas, is defined by the lack of a P wave but a narrow QRS complex. This rate is between 40 and 60 beats per minute. This is a junctional rhythm. As a small side note, because of retrograde activation of the SA node, there sometimes can be an inverted P wave in junctional rhythms in an odd place. Our next rhythm, as we see, has an inverted P wave with a very, very short PR interval. This is also a junctional rhythm. However, because of the accelerated rate of 82 beats per minute, higher than our 40 to 60, this is termed an accelerated junctional rhythm. Causes of acceleration include things like catecholamines or ischemia. This final junctional rhythm is very fast and it's very similar to SVT. However, if you look closely, buried within the QRS complex is an inverted P wave towards the top. You can also see the presence of a T wave. If you still have P's and T's that are separate, you do not have SVT. This is a junctional tachycardia. This rhythm is a result of even further enhanced automaticity, like from sympathetic nervous activation. This next one is one of my favorites. is known as the wandering atrial pacemaker. The name really breaks it down for you. The atria are pacing the rhythm, but it's wandering. It's wandering around the atria. It's not always originating at the SA node. Remember, what qualifies the SA node origin rhythm is an upright round P wave that is symmetrical with a normal PR interval. If we look closely at these QRS complexes, there is variability in both the size and morphology of the P wave for each, the PR interval, and whether it's biphasic or not. Now, if you were to take this rhythm and make it faster, let's say faster than 100 beats per minute, this rhythm is now multifocal atrial tachycardia. So we go from WAP to MAT. Do what you will with that information. Our next rhythm is one that makes people scream. This is ventricular tachycardia. VTach is caused by a reentrant rhythm in the ventricles. VTach often results in hemodynamic compromise due to poor ventricular filling time in the absence of atrial kick. Because it is a reentry in the ventricles, the P waves are not lining up, and therefore there is dissociation. This will come into play in the next lecture. Causes of ventricular tachycardia include ischemia or premature ventricular contractions happening on a T wave. This is called an R on T phenomenon. Remember, our T wave is where repolarization is happening. We should not be having depolarization during repolarization. Duh. This specific rhythm is called monomorphic VTach. It is monomorphic because the morphology is the same every time. This is in contrast to polymorphic VTach, which has different morphology each beat. Monomorphic VTach, due to the regular morphology, can still have a pulse and not be an arrestable rhythm. However, these are still very sick people who have a high propensity to degenerate into ventricular fibrillation. Hint, hint, wink, wink. The RNT phenomenon typically causes polymorphic VTach like torsades, which I will discuss next time. Other causes of VTach are cardiac drug toxicity and electrolyte imbalances. Our last rhythm should get you moving. This is a chaotic rhythm, originating in the ventricles with no cardiac output. I repeat, there is no cardiac output. If your patient has this rhythm, they do not have a pulse and they are not breathing. This is an arrestable rhythm. This is ventricular fibrillation and it is a shockable rhythm, which means you defibrillate them. Alright guys, that's it for the major rhythms to know. I'm going to shout out the visual nurse, Tyler, on Instagram. He has a few great books that I've learned a lot from over the years, and he's worth the follow. I hope you all got something out of this lecture, and please feel free to use the EKG simulator. It's free, and you can make some fun games out of it and learn a lot. I'll see you next time in the last lecture of this series, and thank you so much for listening.